Hello all, welcome to the Study MRCEM YouTube series for MRCEM SBA, Intermediate SBA. So myself, Dr. Solution TP, your course director at Study MRCEM. So today, for the next 10 to 15 minutes, what I'll be discussing you will be regarding the cardiac arrest algorithm as per the UK Resuscitation Council. So we'll just discuss the algorithm first. Then I will take you through some certain scenarios that you need to know and how to handle that and what are the key things that has come with the 2025 updates. As you're all preparing for your SBA, it is very important to know what are the key changes that has occurred after the 2021 updates. Now the 2025 updates have already reached. So you should know what are the major algorithm changes and what are the recommendations given by the UK Resuscitation Council. So we'll be discussing exclusively the cardiac arrest related algorithms today, and then on the upcoming days we'll be discussing various important topics which is relevant for MRCEM Intermediate SBA. So let's see the algorithm first. So you see the very clearly the adult advanced life support algorithm. So it's very clear and very robust algorithm. So whenever a patient collapses in front of you, you have initiated the CPR and you have gone ahead and activated the emergency response and initiated the CPR, and you have the patient is in the in hospital. Then the next important thing that you are going to do is to connect to the defibrillator and to see whether it's a shockable rhythm or it's a non-shockable rhythm. So one of the key factors that you need to understand is that you need to continue the high quality CPR whatever you are delivering. So the qualities of CPR that you need to remember, the ratio of compression is 30:2 and 100 to 120 compressions in a minute. That is the key point, and you have to minimize interruptions, and you have to ensure that there are adequate depth by which you are giving the compression, that is for approximately 5 centimeter or 2 inches. Or, and the next important part, what you need to remember, you have to minimize interruptions and avoid excessive ventilation. And always remember, in case of a shockable rhythm, the shockable rhythms that you want to remember, there are two shockable rhythms that you will be remembering is the pulseless ventricular tachycardia and ventricular fibrillation. So the moment you recognize that it's a shockable rhythm, the next step what you need to do is to go ahead and deliver the first defibrillation. So there are certain energy doses. What you need to remember, everything we will discuss in detail. Uh, and the moment you recognize that it's a shockable rhythm, you deliver the shock and resume your CPR. Then again after 2 minutes you reassess. So that will be the circle that you need to follow up. So and also it is very important that when to give adrenaline. So adrenaline dose is to be given in case of a shockable rhythm only after third shock. Also your amiodarone comes there, and in case of a non-shockable rhythm, as soon as you are able to give adrenaline, you have to administer adrenaline 1 mg 1 in 10,000 dilution. That is the dilution factor that you need to remember. So the key point what you need to remember here, it is that shockable rhythm, the priority is to deliver the shock as early as possible. In case of a non-shockable rhythm, is to continue the high quality CPR and to administer epinephrine as early as possible. And simultaneously, you have to look for the reversible cause of cardiac arrest. So there are a lot of scenarios that you need to keep in your mind. When you have an advanced airway in place, there is no need of synchronization of 30:2. You can give continue compression at a rate of 100 to 120, and you can give one breath every 6 seconds. So there are certain scenarios that you need to be aware of. So let's see. The first thing, start ALS as early as possible. So that's one of the key thing that whatever be the recommendation that you need to remember, start ALS as soon as possible. Hospital system should aim to recognize cardiac arrest and start CPR immediately, that defibrillate rapidly within less than 3 minutes for shockable rhythms, and give adrenaline rapidly for non-shockable rhythm, and identify and treat the reversible causes. So that is one of the key thing that you need to remember. And all hospital staff should be able to recognize cardiac arrest rapidly and call for help, start CPR and defibrillate, and attach an AED and follow the AED prompt, or use a manual defibrillator. In case of a hospital setup, it comes the manual defibrillator. It is not an AED, it will be a manual defibrillator. So coming to the defibrillation. So whenever automated external defibrillation versus manual, so that is the challenge. So manual defibrillator should only be used by a rescuer who can quickly and accurately identify a cardiac rhythm within 5 seconds. You should be able to identify, okay, this is a torsade, this is a VF, this is a VT, and this is an asystole, this is a PEA. And if needed, deliver a shock with a minimal interruption, aim for less than 5 seconds to chest compression. So that is another key point that you need to remember. If an AED is already in use when ALS provider avoid, they should follow it. It shock prompt. So AED already collected, you can continue with AED. When possible, they should transition to the manual defibrillator during the 2 minutes CPR cycle. So whenever you are reassessing the patient during that time, you can convert from an AED into a manual defibrillator. So that is the time frame that you need to keep in your mind. So continue CPR with defibrillator is retrieved and pads are applied. So that's one key point. Till the machine has started switched on and start analyzing the rhythm, you have to continue CPR. High quality CPR improves the chance of successful defibrillation. Give shock as early as possible when appropriate, and deliver shock with minimal interruptions to chest compression, and minimize the pre-shock and post-shock pause. So that is the two things that you have to be very, very clear. This is how you can prevent the pause shock. This is achieved by continuous chest compression during defibrillator charging, delivering defibrillation, aiming for an interruption in chest compression of less than 5 seconds, and then immediately resume chest compression. So that is the one key factor that you need to remember. Immediate defibrillation of VF of any amplitude, even 5 VF should be given. So even if it's a fine VF, you have to immediately defibrillate the patient, immediately resume CPR, and after the compression, after the shock delivery, you have to resume the CPR. So that's the one important point that you need to remember. Now, safety while defibrillation. That is the another area where the algorithms have been representing. Minimize the risk of fire by taking off oxygen mask, nasal cannula or back mask, placing them at least 1 meter away from the patient's chest. So that is the one of the recommendation. And when using a mechanical ventilator or oxygen, exhaust from the ventilation circuit should be directed away from the chest. A self-inflating bag or the ventilator circuit should remain attached to the supraglottic airway or tracheal tube. Charging the defibrillation in anticipation of each rhythm check may minimize the handoff time prior to the shock delivery and is acceptable alternative strategy if delivered without prolonging the peri-shock pause. A shock with a manual defibrillator can be safely delivered without interrupting mechanical chest compression. Do not defibrillate during manual chest compression. So that is very, very important. Even wearing gloves, clinical gloves, as the practice is not safe for the rescuer. So that is very, very crucial point what you need to remember. Now the paddle position. So anterolateral position is the position of choice for initial paddle placement. In particular, ensure the lateral pad is positioned correctly directly below the armpit in the mid-axillary line, and consider an AP for vector chain defibrillation following 3 failed shocks. So that is again one of the recommendation in case of refractory VF. The anterior pad is placed to the left of the sternum, avoiding as much as breast tissue as such as possible, and the posterior pad is placed at the same height, centered medial to the left scapula. In patient with an implantable or a defibrillator ICD, you need to place it 8 centimeter away, and consider an alternative pad position when the patient is in prone position, that is biaxillary. So when you have to do a prone ventilation for an ARDS, where to keep the paddles, that is a question. You can give biaxillary. If you're unable to fix AP, you can keep biaxillary also. That is the another recommendation. Now coming to the crucial part, the energy level. Use single shocks followed by a 2 minute cycle of chest compression. So that is the general recommendation. The use of 3 stack shock. So that is one major thing. Routinely when we do this, we are not practicing, but you can do 3 stack shock, may be considered only if the initial VF or pulseless VT occurs during a witness monitored cardiac arrest with a defibrillator immediately available. Example, during a catheterization, cardiac catheterization, or in a highly monitored ICU setting. So 3 stack defibrillation is one thing that you can try for your VF and VT. And for the purpose of adrenaline amiodarone administration, the initial stack should be counted as the first shock in the algorithm. So the 3 shocks, whatever you are delivering, should not be counted as 3 shock. It is to be considered as only 1 shock that has been given. So that is the one crucial point that you need to remember. Now coming to the energy level for biphasic form, rectilinear biphasic or truncated exponential biphasic, defibrillation energy is usually you can start off 150. You can for pulse waveform deliver the first shock at 130 to 150, but we have doubt in your mind, you go ahead and give the maximum dose whatever is available in the defibrillator. If you have doubt in your mind, if you are giving the further shocks like you're given 150, the further shock should be increasing in the energy. So if you're given 150, the second shock should be 200. So if you have in doubt, give the maximum energy whatever is available in the defibrillator. And for the obese patients also, it is the standard energy what is recommended. Coming to the refractory VF management. So considering escalating the shock after a failed shock, that is what I have already told. For refractory VF, when we say refractory, you are given 3 shock till the VF is not settled. So we call it as a refractory VF. So as I told you, you can try to change the paddle position AP. And after a failed third shock, prepare for a place of fresh set of pads in the AP position at the time of following the rhythm check. Further optimize transthoracic impedance by shaving the anticipated area of pad placement. And double sequential defibrillation is one thing that we used to do, but there is no recommendation, there is no evidence as such. So, routinely it is not being recommended, but there are anecdotal, lot of literature review has come up, but you can give it a try, but generally it is not recommended by the Resuscitation Council of UK. Coming to the very important vascular access, intravenous access is the ideal one, but IO access is also acceptable to enable drug delivery. If IV access cannot be achieved within 2 attempts, it is reasonable to consider IO access as an alternative route for vascular access during cardiac arrest. Coming to the drug, as I told you, adrenaline 1 mg as soon as possible for adult patient in cardiac arrest with a non-shockable rhythm. Give adrenaline 1 mg only after third shock for adult patient in a cardiac arrest with a shockable rhythm, and repeat adrenaline 1 mg every 3 to 5 minutes while you are continuing the ALS. Coming to the antiarrhythmic drug, amiodarone. Give amiodarone 300 mg IV for adult patient in cardiac arrest who are in VF or pulseless VT after a total of 3 shocks has been given. Give a further dose of amiodarone 150 mg IV for adult patient in cardiac arrest who are in VF VT after the 5 shock has been given. You can replace amiodarone with lignocaine also. The first dose is after of amiodarone is after third shock, and the second dose after 5 shock. That is the remember what you have to do. If you are replacing it with lidocaine, it is 100 mg IV and 50 mg in place of amiodarone. Coming to thrombolytic agents, yes, you can try thrombolytic drugs. Consider immediate thrombolysis, especially when you have pulmonary embolism related cardiac arrest. So you are having a low ETCO2. You have tried for the quality of CPR. You have improved the quality of CPR. Still, the ETCO2 is less than 13, and there is a high risk for PE. You can think about a PE, and you can even thrombolyze. Even that holds good for myocardial infarction. In selected patient with suspected pulmonary embolism, consider CPR for 60 to 90 minutes after administration of thrombolytic drugs. Fluids, yes, give fluids only if cardiac arrest is caused by hypovolemia. Use either isotonic or balanced crystalloids for fluid infusion during CPR. And other drugs, there are no routine use for calcium. Yes, when you have hyperkalemia, you can give bicarbonate, severe acidosis with hyperkalemia. Steroids, there are no role during cardiac arrest. So these are the things regarding other drugs. Now, can be an other scenario, ALS in highly monitored cardiac arrest and physiology guided CPR. So, a sudden decrease in ETCO2 may indicate a cardiac arrest or a very low cardiac output, especially in an ICU setup where there is already an intraarterial line. So, consider starting stress compression if the systolic blood pressure decreases and remains less than 50 despite interventions. In an adult undergoing continuous intraarterial blood pressure monitoring, we suggest that adrenaline is given as an initial small increment rather than 1 mg, 50 to 100 microgram IV rather than 1 mg boluses. If a total of 1 mg has been given with no response, ensure that there is no extravasation and consider giving further IV dose every 3 to 5 minutes, that is 1 mg. A pragmatic approach during physiology guided CPR is aimed to bring up a diastolic blood pressure of above 30 and an ETCO2 above 25 mmHg. So that is the approach that you need to keep in your mind. Waveform capnography during ASLS, yes, very important. It can guide you the two position when you are intubating. Also, the quality of CPR, if it is less than 10, you need to improve the quality of CPR. As I told you, if after improving the quality of CPR also, the ETCO2 is very low. If you have a high index of suspicion for PE, you can think about thrombolysis. A rapid increase in ETCO2 will tell you, okay, this patient have achieved return of spontaneous circulation. However, chest compression should not be interrupted based on this sign alone. Use a combination of clinical and physiological signs of ROSC. And one other, if we are persistently uh, low ETCO2, if resuscitation attempt should not be stopped alone, it should be multiple factors. You have ruled out all the reversible causes, and you have ensured that the quality of CPR is good. Then you can think, okay, after 20 or 30 minutes of CPR, you are not getting a return of spontaneous circulation. You can think about stopping your compressions. Focus in cardiac arrest, yes, very, very important. Only skilled operators should use intra-arrest point of care focus. Focus must not cause additional or prolonged interruptions in chest compression. Focus may help identify a treatable cause of cardiac arrest such as cardiac tamponade and tension pneumothorax. And right ventricular dilatation in isolation during cardiac arrest should not be used to diagnose PE. So that is in a routine scenario, we will diagnose it as a PE, but not during cardiac arrest. Do not use focus for assessing contractility of the myocardium as a sole indicator for terminating the CPR. So thank you for all for listening to this video, and I hope it was very clear what is the ALS cardiac arrest algorithm that guides you. There are certain scenarios like cardiac arrest in special scenarios which we will discuss in the upcoming YouTube series. So if you are interested to join for our SBA program, you can contact any one of us, and the contact numbers and the details are given in the screen in front of you. Thank you for your patience listening.